ASH 2015 coverage here at Orlando, Florida. Thomas Baldrick joined now by Dr. Simon Mantha from Memorial Sloan Kettering in New York. Thanks for taking a couple moments out of your conference for us.
Thank you.
So you got a study on safe and effective use of Rivaroxaban for patients with cancer VTE. Let's talk about the risks first of treating these patients.
So the current gold standard of treatment for this condition would be an injectable, a type of low molecular weight heparin, and it's actually far from being perfect. There's a rate of recurrent VTE of about 9% at 6 months with this treatment, and a substantial risk of bleeding as well.
So you make use of Rivaroxaban. Tell us what you did with this study and why you chose to do it.
So we performed a quality assessment study. We accrued patients to whom we offered Rivaroxaban versus Lovenox or enoxaparin, and we accrued that in over a year's time, or a little more, 2014 until November of this year. And our plan was to have 200 patients in a cohort, which we achieved. And as of mid-November, we had 6 months of observation on all 200 patients in the cohort, hence the analysis, which is going to be presented Monday next week.
What did you find in terms of rates of major bleeding?
So the rates of major bleeding at the 6-month endpoint were only 1.6%, while the risk of recurrent VT was 4.4%, which is much lower than what was found in the landmark studies CLOT and DeltaCan. However, you cannot really compare directly a randomized study that happened 10 years ago or even more recently to such a retrospective study, but still it gives you an idea of the ranges.
What else was significant to you?
So those are the two most important endpoints, recurrent VTE and major bleeding. Also, there's an endpoint called clinically relevant non-major bleeding, which is a milder form of bleeding. And it also was about 4% in terms of risk at 6 months, which is very good. As far as the risk of death, there were no deaths related to bleeding or thrombosis as far as we could tell in our cohort, which is very important, obviously.
So where do you go next with this research?
So ideally, if we had the funds, we'd like to do, or anybody I'm sure would like to do a large randomized study comparing one of the low molecular heparins to Rivaroxaban. However, there's reasons why this might never get done. So I think the next best thing would be to do other larger cohort studies like this, possibly more perspective with perspective assessment of the outcomes, because what we did a retrospective assessment of the events, which opens the risk of observation bias, of information bias. So ideally, if you want to do better, short of a full randomized study, you would do a prospective study where you would observe the patient and accrue events prospectively.
Well, keep us posted, Dr. Mantha. We appreciate it.
Thank you.
Thank you, sir.